I am Dr. Khalid Khan. I'm a physician at the MedStar Georgetown Transplant Institute, and I am the medical director of the Islet Transplant Program. I specialize in diseases of the pancreas, specifically chronic pancreatitis is an expertise of mine. Well, the main problem the patients have with the pancreas is pain. The pancreas actually produces all the digestive enzymes that go to the intestine and usually help digest your food. In pancreatitis, they actually digest the pancreas, so-called severe pain, and there are specific conditions that give rise to that. So severe pain is usually the main symptom that our patients have when they come to see us. There are two big areas of frustration for them. One is that they don't have a diagnosis, they have the pain. People have tried and thought of pancreatic disease, they've tried treatments and they've tried investigations, and often they've failed. So therefore they feel that of course it's not the pancreas, so it must be something else, and when there's no other diagnosis, often physicians will give up. The other thing is, of course, dealing with the pain itself, and this is a much bigger problem because these patients often need narcotics, they often need to go to the emergency room, they often need to go to physicians for really what are very strong painkillers. In another word, of course, this is opiates, and when you need a lot of opiates, it's very easy to get labeled, if you look otherwise well, as somebody who is drug seeking, and that's almost universal with the patients we see by the time they get to us. So you can imagine the stigma associated with that for these patients. Not only they know that they're suffering, but at the same time they're being accused of course, being malingerers and drug seekers. The main goal of the islet cell transplant is not actually the transplant itself, but it's to remove the pancreas that's causing the severe pain. The islet cell portion is an additional benefit in that we remove the islets from the pancreas and put them back in the patient so that they don't become diabetic. Otherwise, if you just took out the pancreas, you would have fixed the pain, but you would also be a very bad diabetic. The biggest reason for actually coming to see us is this: even if you have pain and you don't know where you have what the pain is due to, our expertise is such that we can actually identify people who really have this severe problem and deal with it. We can tell you straight away or after investigation whether this is an issue, and it can save you years of pain that is likely to happen otherwise, because people do not make the connection, first of all, between the pain and the pancreas, and even if they do not recognize the fact that islet cell or total pancreatectomy with islet autotransplant is the right treatment. Nobody's going to alter your life by taking the problem away, because there are very few places that do that, and this is one of them. Well, the pancreas is an endocrine and exocrine gland. It has two functions. One is that it produces enzymes that help us digest our food that we eat, and the other is it produces insulin through little cells on the surface of the pancreas called islet cells, and that allows you to control your glucose. Islet cells are small, literally islands, that's why they're sort of named that way, on the surface of the pancreas gland. And what they do is they sense glucose in the blood and they produce insulin so that they prevent blood sugar going very low or very high. Now, when you produce insulin from those little glands, it actually goes throughout the body and it allows the other organs or your tissues to take up glucose in as much as you need. So it's a kind of facilitator of glucose transport to other organs and use. And that's everywhere from your liver or any organ in your body to your muscles and of course eyes, you name it. Of course, this is how glucose is allowed to function and go to the right place to provide energy. Chronic pancreatitis is a process of inflammation. Of course, anything with itis in it implies that there's inflammation. There's acute and chronic pancreatitis. Acute pancreatitis can happen suddenly if you have gallstones and your pancreas swells up. The reason it becomes inflamed is something blocks the exit of the enzymes that you're producing for your food, blocks them in the pancreas, so all of a sudden they start digesting the pancreas, and that's very painful. Now that's acute pancreatitis. In the chronic situation, this is happening all the time. Perhaps not as severe as in the acute, but it happens constantly or happens repetitively for one of many reasons. And that means that you have constant pain, chronic pain, recurrent pain each time you're getting any inflammation in the pancreas. And of course, therefore, as it becomes worse in that there's continued damage of the pancreas, you lose the function itself because you've literally destroyed the glands, so you have no ability to produce the enzyme to digest food, so you develop diarrhea, and you have no ability in terms of producing insulin because you've destroyed the islet cells, and therefore you become diabetic. Chronic pancreatitis eventually will lead to pancreatic cancer. Now, I want to qualify that most people who develop pancreatic cancer, which is a common cancer, do not have chronic pancreatitis because cancer itself is a common problem. But for any chronic disease with inflammation in any part of the body, the consequence often is over 20, 30 years of developing cancer, and chronic pancreatitis is exactly that process. But remember that most people will have chronic pain for 20, 30 years, and a lot of things may happen during that time. First of all, somebody may have the pancreas removed, so there are a lot of changes in that time frame. So or because you have chronic pancreatitis, you can monitor for pancreatic cancer if, of course, you don't treat it in the way we treat it. The theory is that pancreatic cancer itself, whether it's related to chronic pancreatitis or not, occurs because of what we call multiple hits to an organ. Now, of course, as you know, that the body regenerates. Everything we do, of course, has a turnover, much like cells on your tongue to a lot of other things that we actually know, we understand, but the body regenerates all the time. And when it regenerates, these processes can go wrong, and that's the process of cancer. Now, when you have it in the pancreas, remember the pancreas is always doing something. It's producing enzymes. It's a very active organ, so the chances of developing cancer, of course, happens in tissues that turn over like that. Now, when you damage the pancreas, of course, you're damaging at a genetic level more often because you've got chronic inflammation. So each hit that you get has to be repaired. And of course, the more you have to repair, the more chances that something is going to go wrong. And that's the process of cancer. The simplest way to diagnose acute pancreatitis is a blood test. So if you go to the ER with severe pain and you're doubled over in pain, they're going to check two enzymes, the amylase and lipase. These are digestive enzymes that get released actually into the blood because there's so much of them coming out of the pancreas, and we can detect that. So that tells the doctor that you've got acute inflammation in the pancreas. Now, chronic inflammation or chronic pancreatitis is different. By that time, you don't release a lot of these enzymes because you're actually releasing small amounts, and sometimes you've exhausted the supply of enzymes. So in chronic pancreatitis, the diagnosis is very difficult because there is not a simple blood test. There are imaging technologies like MRI, CT scan, or even ultrasound that can show a swollen pancreas or an abnormal pancreas that's been damaged. But unfortunately, in chronic pancreatitis, they can also be negative. And that's the problem, because this is one reason why patients with chronic pancreatitis often, when they go through this gamut of tests and everything is normal, the physician comes to the conclusion that there's nothing wrong with you because all the imaging is normal. What we know is that you've got to delve a little bit deeper in terms of the pain. You've got to be more subtle about how you look at the x-rays and imaging to be able to make those subtle cases. And I think this is one reason why patients go from one physician to the other, because they're looking for a cause, and people are saying, well, this looks like pancreatitis, but we can't tell that there's anything wrong. So we've developed more subtle testing, particularly for testing glucose and insulin, to actually take it one step further, so that any cases that may seem like they are not chronic pancreatitis, but in reality are, we can perhaps, let's say, sift them out. We limited to 2, and we published our findings, obviously for everybody's benefit, because all the other tests we felt that were often negative. And the 2 tests are, first of all, an MRI, high-resolution MRI, specifically aiming at the pancreas rather than looking at every organ in the abdomen, which is the way normally you would do it when you're doing an exploratory investigation. So you have to be very specific and look at the pancreas in multiple different ways with the MRI. And then also we look at the glucose profile in people in a continuous manner. So for 5 days, we actually have a little probe that checks your glucose continuously. And we know that the subtle changes in that monitoring process are the ones that really tell us those patients who are very early on in this process or have a mild degree of damage that otherwise looks like there's nothing going on. Beyond that, there are a lot of tests, but often if they're abnormal, if these other tests are abnormal, of course, by this time you already have a diagnosis. But we find that most patients with chronic pancreatitis, when they can be diagnosed on these regular tests like CT and ultrasound, your pancreas is effectively dead by that stage anyway. So to wait to get findings on these other imaging techniques is, of course, too late. The universal symptom is chronic pain. It may have a recurrent quality to it, but there's usually, most people describe a background level of pain that they may or may not tolerate without medication, and then there's always episodes where things are much worse, and those can last just after a meal, or they can last for days, and there's really no pattern often. But what they do know that there's a pain in the abdomen, that they're doubled up, that they can't do things, and it's very difficult to control that even with very large amounts of medications. Well, the islet cell transplant it sounds like a very complex procedure, but in reality that part of it is the most straightforward. The islet cells themselves, as we were saying, come from the pancreas. For chronic pancreatitis, the pancreas is removed, take away the pain. Now that pancreas is then digested in the lab to take away all the other tissue that you have and just isolate the islet cells. And as we were saying, the reason we need the islet cells is because they produce the insulin. So you want to keep those and get rid of the rest of the pancreas. And well, where do they go after you have them in your hand? Or let's say you've created the islet cells now, where can you put them back in the body? Because they've got to go back to be functional. Now most people, of course, there are very few people who do this, but the standard right now is to put them back in the liver. So they come much like a transfusion of blood. It's not blood cells, but islet cells. And the procedure during the time that the pancreas is removed is to literally infuse them, just like you would with any fluid, into the liver through the portal vein. So that's the whole process. The surgery is a long surgery, and we've developed a process, much like other transplants or other major surgeries, to make sure that it goes well. And indeed, a lot of our work and our research is based on maintaining and improving that sort of safety profile. It's a long surgery. The pancreas is a gland that sits at the back of the abdomen, so it takes a long time for it to be, let's say, removed. It takes 2 or 3 hours for the pancreatitis to be digested. So during that time, people are in the OR, making sure the patient is fine. And then the islets come back as an infusion, and they get infused, which usually only takes 20-30 minutes. But when you add all the rest of the time period, it can be about 10 hours, 8 to 10 hours, 8 to 12 hours, depending on how difficult it was and how damaged the pancreas was. Yes, in general, the more islet cells, the less likely you're going to have diabetes of any form. And that makes sense, of course, intuitively, but you have to remember that anybody with chronic pancreatitis, by definition, has an organ that's very damaged. So it's a given that you're not going to get as many as you would if the pancreas was not damaged. So when you go into a pancreatectomy and auto-islet cell operation, you have to be resigned to the fact that you're not going to get as much function out of the islets as somebody who didn't have pancreatic disease. So it's a given that that a proportion of people will be a little diabetic because they just don't have enough to start off with. You can, in that if you don't have the exocrine function, i.e. the enzymes that you produce to digest your food, you can. Of course, without insulin, you can't. We know that because without insulin, you can't process glucose. But in terms of the digestion of food, the human kind of alimentary tract or intestine is complex enough that it actually let's say, it can digest food with very little help from the pancreas. And we know that because some people whose pancreas come out actually need very little support. But we do have treatment for that, which is the same enzymes but in a capsule. And so, of course, normally, just like the pancreas would produce enzymes when you eat, you basically take a couple of capsules with the enzymes when you eat, and actually that normalizes your ability to digest food. You would, because if your pancreas dies because of chronic pancreatitis, you need the enzymes. And of course, if you take the pancreas out, you need the enzymes because to digest the food, those enzymes are necessary. They literally break down physically food that enters the stomach and moves on to the intestine. Pancreas transplant is reserved for the most severe diabetics because those are the people who are going to die because of severe low and high blood sugars. So this is why it's not translatable straight away to dealing with, a pancreas transplant is not an easy fix for chronic pancreatitis. You may need insulin either in the short term or long term or not at all. So those are 3 possibilities. It's not always possible to tell before transplant because our testing is not sophisticated enough to tell us how many islet cells or how functional those islet cells are going to be. So we have a ballpark idea because of the testing that we've talked about, but inevitably the only way to know is when that pancreas comes out and we get the number of islets and they go in. We have an estimate at that time. If there's a lot of islets, we can be pretty confident that you're not going to be diabetic. But if you find that we only got a quarter of what would be in the pancreas, then we have to admit that you're going to have some diabetes. But usually people come out in the middle. After an islet cell transplant, after the surgery itself, we usually say that it can take you up to a year in terms of getting back to normal. And the year is there because of the high doses of narcotics that people used to take, the debility that they have from not moving and not being able to do things. So, but in terms of the surgery itself, much like any other surgery, you are out of hospital within a week or two. You can do normal things, walk around. After 6 weeks, you might be able to lift a little weight so that you don't develop a hernia. But that's not related to the eyelid surgery, it's related to any surgery that we have. And then, of course, 3 months, you're able to do more and so on. So it's more like that. But the true complications from before the transplant, which is the heavy use of narcotics, often, the poor nutrition because you haven't been able to eat because of the pain, that rehabilitation, to my mind, usually takes a year for you to get through all those different problems that you've kind of accrued beforehand. Timeliness is crucial to management of chronic pancreatitis when it comes to total pancreatectomy and auto-islet transplant. And the reason is, of course, the longer you go without a diagnosis and without the treatment, the more the pancreas itself is going to be destroyed. Therefore, the fewer islet cells you're going to have available after the surgery. Well, the lab is fundamental. I mean, without it, we wouldn't have the program. And the reason is not only the standard in terms of the islets we produce, but also having the consistency of producing material that you actually have to use in human beings. So the degree of, let's say, scrutiny is very high. And what we did at this lab, of course, is that we went through the FDA and so forth to obtain standards that you don't usually even need for auto-islet cell transplant. And the reason for that, of course, is that it's like anything. If you're going to do it, if you do it well, of course, it benefits the patients and inevitably makes you sleep better, because while it does cost more and it means that you're using standards that probably are not necessary and certainly not performed in other centers necessarily, that it allows you to give the best possible care. Our ability to isolate islets is second to none. So we have a state-of-the-art facility to process islet cells. By definition, we know, whether you look at efficiency of any car or anything, that's what matters if you want to have quality. And that's perhaps, if for no other reason, even if the physicians may be the same, you are not going to get that kind of quality everywhere.